Hello, everyone. I'm Dr. Haewon Shin. I am the Executive Director of Sumang Society. Thank you for joining us today for this important discussion. At Sumang Society, we provide education on advanced healthcare directives and advanced care planning for older Korean Americans and their families. Advanced Healthcare Directives is a document that ensures individuals' healthcare preferences are respected when they are no longer able to make decisions for themselves. To date, over 18,000 older Korean Americans and their family members have completed their advanced healthcare directives through our program. Today, we are so honored to speak with Dr. Daniel Oh to explore how having or not having an advanced healthcare directive can impact the medical care that patients receive in emergencies, such as cardiac arrest or traumatic brain injury. We'll also discuss how these documents affect the decision-making processes of families and healthcare providers. Dr. Oh, thank you so much for joining us today. To begin, could you please introduce yourself to our audience?
Hi, thank you for the invitation. My name is Daniel O. I'm a vascular neurologist or a stroke specialist, and I take care of patients who are in the emergency room or admitted in the hospital with severe brain injuries like major strokes. So I work in the hospital and I see a lot of patients who are not able to, speak anymore or in a tough situation with compromised level of consciousness. So dealing with emergencies in neurological care is my day-to-day work, and I'm glad to be part of this talk where we talk about advanced care planning and how it helps really importantly in guiding treatment decisions. Thank you.
Thank you. So let's assume a patient, the completed an advanced healthcare directives, and when this patient is hospitalized unexpectedly due to, for example, a cardiac arrest or a head injury, how is the directive applied in the actual treatment process? What steps do medical professionals take to verify the existence of such document? And are the patient wishes fully honored as stated in the advanced healthcare directives?
Yeah, that's a great question. So I can give a quick overview of how the emergency room doctors or the acute respondents can go through sometimes electronic health records or medical records or patients' wallets if they have it with them, or sometimes in their watch to verify any sign, a modicum of advanced directive. And advanced directive obviously can list out what their wishes are in situations where they can't speak for themselves. So it's very important to us. Sometimes in a wide network like Kaiser, where there's a strong health record electronically, we can you look it up in a click. Sometimes that easy. A lot of times you don't have something written available, immediately available. So it can be challenging. But if we have it available, we do everything we can do within medical possibilities upfront to respect their wishes and even read between the lines if it's not spelling out every condition possible. So it is sort of the guiding pillar, and we very much appreciate and look forward to having one so we can do what is best that the patient wanted. So it's really a guiding principle upfront, emergently.
Oh, thank you. So we heard advanced healthcare directives and another terminologies, POST, as well as DNR. Could you explain the difference among those advanced healthcare directives, POST, and DNR?
Yeah, and it's very confusing. These are all efforts to document what the patient wants or what might be the best for the patient. So they're all directions of some sort. So the widest, the most encompassing of all is the advanced directive or AD. This is sort of a free writing. You can write whatever you want in your funeral, your wishes, if something bad happens to you or you lost consciousness and you can't speak for yourself. So it's a document that the patient writes and leaves for themselves, a certified document, a legal document. The next broad term is the POST or POST or physician orders for life-sustaining treatment. These are completed by the providers, physicians, for patients often in palliative care, hospice cares, those who don't have a great prognosis. So these are the physician's recommendations, usually in conjunction with the patients and the family's requests, but it lists out very clearly in checkbox format what is optimal for the patient in terms of intubation or a gastric tube, alternative feeding methods, what level of escalation and higher level of treatment they want or don't want. So these are for seriously ill patients, and it's often a pink form in one page, and it's very standardized, so every doctor can go by those guidelines. The most narrow of all, these directives is the DNR form, and I think people have been really familiar with that since COVID. But DNR stands for Do Not Resuscitate. This is specifically the most limiting form, and it applies to really whether patients want the CPR or resuscitation or not. So if the heart were to stop, do you want someone doing chest compressions on you? So it really just addresses that one life-saving technique.
Thank you. That's very clear. Thank you so much for explaining the difference among those. And so let me ask you, if a patient arrives at the emergency room unconscious due to an unexpected accident and has not completed an advanced health care directive, what protocols do hospitals and medical staff follow? How are treatment decisions made in such a situation? And additionally, if the patient had previously expressed to family members that he or she did not wish to receive life-sustaining treatment, how is that verbal statement treated under medical and legal guidance?
All right, that's a very important question. So, in the absence of the advance directive or post or any of these directives, the emergency team or the medical team, the emergency room or ICU, we have protocol to default to saving life, to protect airway, secure circulation. So that's the most important when there's no guidance whatsoever. So they will default to intubation and other life-saving measures. If there is a loved one or caregiver, family, or whoever shows up on site, and that's all we know about. And as a surrogate decision maker, even if we don't really know, if you can't prove that they're a decision maker, we do respect, within reasonable guidance, medically possible, that if they do have those things that are verbally said before or wishes, we do take it at face value. There are times where things get complicated, whether each state has their own designation and qualification for who becomes the closest decision maker, the surrogate, the power of attorney, these terms that I can't get into it right now, but we do our best upfront, at least within the people that are in the emergency room or the scene. We try to respect and read between the lines, interpret some of those wishes that were verbalized to apply it to that situation at the time. So if there's a clear verbalization that's been reverbalized by the family members and the loved ones and decision makers bedside, then we do avoid sometimes resuscitation or intubation, things like that, the emergency sort of acute therapies. But there are times when things are confusing when the caregiver who showed up on site refuses to or defers any decision making, which does happen, and passes on the decision making to another family member. And that process of searching who the right delegate is can take a long time, of course, without written documentation from the patient themselves.
Oh, okay, gotcha. So my next question is, conflicts can sometimes arise between a medical team's clinical judgment and the values or wishes of the patient family, particularly when it comes to life-sustaining treatment, because it's a big decision. In such cases, what procedures do hospitals follow to reach a decision, and how are ethical dilemmas mediated in the hospital setting?
Yeah, that's another really good question. So in the absence of an advance directive, it gets trickier because we have to read between the lines and interpret and apply to that circumstance. If there is a clear reversible condition that the medical team or the ICU team is offering, whether it's something more invasive or a treatment course, usually the families wouldn't disagree to that. But if it happens so that there seems to be a poor prognosis or an actually neurologically poor outcome, which we don't have a crystal ball for, but if there's reasonable concern from the doctors and the multidisciplinary team that the patient won't have a quality of life or have a tough outlook, you might get into these situations where the family wants to do as many things as possible while we wait for the unknown date or possible recovery.
Thank you so much, Dr. O. So I think conflict can sometimes arise between a medical team's clinical judgment and the values or the wishes of patient family, particularly when it comes to life-sustaining treatment. In such cases, what procedures do hospitals follow to reach a decision? How are the ethical dilemmas mediated in the hospital setting?
Yeah, that's a very good question and a tough one. So each hospital has a bioethical team and escalation measures to make sure the treating doctors and their loved ones, family members, and the patient's wishes are sort of reconciled and worked together. So at Kaiser especially, we have a bioethics team. They don't get involved with every care or every difference there is between the medical treating team and the family members, but our priorities are both trying to do what's best for the parent, for the patients. We do respect the family's religious, ethical, and other values. So what we'll do is we'll meet together in a multidisciplinary meeting with the social worker, caseworkers, palliative team sometimes, expect consultants, the primary team, the treating team, ICU team, and even myself sometimes for neurology. And especially for life-sustaining treatment, it's tougher when the prognosis may change within days or the outlook is tough. In the gray area, often we try to meet together to hear out their opinions, to work through differences and to really offer what's medically indicated and possible even. So we can't take all their suggestions and respect all their wishes, but within reason, we try to give them time to see where the patient goes, as in we try to see what, how the patient declares if the condition is getting worse or bad, and if the existing, treatment plan is even going to do much. So the conversation sometimes is dynamic, but we have multiple meetings if necessary and have measures of escalation to really address the treatment plan at hand.
Thank you. Lastly, as a physician, what advice would you like to offer patients and their families regarding end-of-life care and medical decision-making?
Yeah, I thank you for asking me that question, offering me an opportunity to pitch in. So the advanced directive, these written documents is vitally important. It represents you in urgent, circumstances and emergency care up front. Writing down your wishes and values and letting your loved one know also protects you and your family members so that there's no infighting, no guessing game, there's no conflict within your loved ones. And it's a very tough deed sometimes to be able to spell out these things, but as long as you have a sentence or two, we can interpret it to really meet your values and your wishes in end of life stage. And we all don't want to be there, but once there's something written and the advanced directive is there, it really smoothens the treatment process so that we all agree and we know what you wanted for your end of life moments. So I encourage everyone, and especially those with chronic conditions, seniors, to really work on that sooner than later. It's almost like a statement of love, and it's the best you can do for things that are unforeseen. Thank you.
Oh my God, thank you so much, Dr. O, for your insight and for helping us understand the critical role that advanced healthcare directives play in medical decision-making. Your expertise provide much-needed clarity on a subject that affects so many lives, especially in times of crisis. We hope this conversation encourages more individuals and families, as you mentioned, to encourage and engage in these important discussions and to prepare for the unexpected with compassion, clarity, and dignity. Thank you again. Thank you so much.
Thank you, Dr. Shin.
This video was made possible through the generous support of Seoul Medical Group, SMG, and the Korean American Community Foundation, KCF.